Welcome. My name is Valentina D'Annunzio, PGY2 in Internal Medicine at Orlando Regional Medical Center in Orlando, Florida. I will be presenting a case titled What Started in the Bedroom Ended in the OR, the case of a rare cardiac mass. We present a 26-year-old male with a past medical history significant for anxiety, episodic nocturnal palpitations, and intermittent chest tightness, presented to the emergency department after experiencing a transient expressive aphasia, facial flushing, lightheadedness, and gait instability immediately following sexual intercourse. The neurological symptoms last only seconds and were followed by a brief posterior headache. He remained alert through the episode. Initial evaluation during the current presentation included vital signs, laboratory study, physical examination, electrocardiography, and non-contact head CT was remarkable. Transthoracic echocardiography with bubble study revealed a large, mobile peduncular left ventricular mass attached beneath the mitral valve apparatus, as you can see in figure number 1. The mass demonstrated heterogeneous echogenicity with feature concerning for superimposed thrombus. Further evaluation with cardiac MRI demonstrated a well-circumscribed peduncular left ventricular mass attached by a narrow stalk to the inferior lateral wall. The lesion exhibited signal characteristic and delayed gadolinium enhancement consistent with myxoma, with large areas suggestive of organizing thrombus, as you can see in figure number 2. The patient was evaluated by cardiology and cardiothoracic surgery. He subsequently underwent successful surgical resection via median sternotomy under cardiopulmonary bypass. Intraoperatively, a soft gelatinous pedunculated mass was excised. Histopathology confirmed a benign myxoma with organizing thrombus. In figure number 3 and 4, we showed a cardiac myxoma with the nest and cords of cells surrounded by a copious mix of stromal substance. These nests and cords are adjacent to surrounding blood vessels. The cells are polygonal with abundant eosinophilic cytoplasm, oval nuclei, and inconspicuous nucleoli. In figure number 5 and 6, we can see the immunohistochemical staining shows a strong and diffuse cytoplasmatic and nuclear staining, supporting the diagnosis of cardiac myxoma. Post-operative recovery was uneventful, and the patient remained hemodynamically stable without complication. He was discharged on anticoagulation and rhythm control therapy. At 9-month follow-up, the patient remained asymptomatic, with no recurrence of neurological or cardiac symptoms. He continues to undergo annual echocardiography surveillance with no evidence of recurrence. Cardiac myxomas are the most common benign primary cardiac tumors, accounting for approximately half of all primary cardiac neoplasm, with the majority arising in the left atrium. Left ventricular myxomas are exceptionally rare, representing only 1.7 to 3% of the cases, and their uncommon location often leads to diagnostic challenge. Despite their benign histology, myxomas may result in serious complications due to intracardiac obstruction, systemic embolization, or inflammatory cytokines release. Clinical manifestations depend largely on tumor size, mobility, and size of attachment, with embolic events occurring in up to 30% of patients and potentially involving the cerebral circulation. Echocardiography remains the cornerstone of initial diagnosis, while cardiac magnetic resonance imaging provides critical tissue characterization that help differentiate myxoma from thrombi or malignant tumors through typical signals pattern and gadolinium enhancements. Prompt surgical resection is the treatment of choice and is generally curative, with low recurrence rates in sporadic cases, when complete excision is achieved. In the presented case, the patient's transient neurological symptoms were most consistent with embolization from a mobile left ventricular myxoma with superimposed thrombus. The absence of extracardiac manifestation, negative family history, and negative genetic testing supported the diagnosis of an isolated sporadic myxoma rather than a syndromic process such as Carney's complex. This case highlights the importance of early recognition and multimodal imaging in young patients presenting with cryptogenic neurological symptoms, as timely surgical intervention can prevent potentially life-threatening complications. Thank you.